Now, moving along with the agenda of this webinar, we're going to ask Dr. Daniel Salas, Executive Manager of Comprehensive Immunization Special Program at PAHO in Washington, for him to open the session with a few words. Dr. Salas, please. Yes, thank you very much, Pamela, and I welcome all of you to this very important webinar that we will be conducting over the next couple of minutes. This is the 24th edition of the Vaccination Week of the Americas. On week 26, this is an invitation to bring all the Americas together throughout the continent as we seek to highlight and reposition the importance of vaccines to ensure that we have a healthier, more protected world with greater opportunities for everyone, especially children. This is very important that the vaccination schedule continues to be applied and that it be a bastion in our countries. This becomes increasingly important for some vulnerable groups, older persons, pregnant women. But throughout this week, well, there was rather an outbreak that started in October 2024 to emerge, and at that time we had 466 confirmed cases, but then there was a huge jump in 2025, and we started to see outbreaks in other parts of the world. Canada went to US and Mexico and a host of countries in Latin America, in Belize as well. There have been outbreaks, and in 2025 there were 14,000 cases in Americas, and thus far in 2026, 17,000 cases is how many we have had or are reaching. So over 2,000 all told between 2025 and currently, and this is a call for us to keep working because there are pockets that are of susceptible people that have not been vaccinated. Either they don't have access to healthcare systems, others because they are hesitant. And we know that healthcare professionals are the ones who are responsible for backing up the population, being the backstop for their health, to protect their health and that of health workers. But if we don't do this, we don't avail ourselves of this opportunity, because sometimes people get the wrong messages on misinformation on social media and then become hesitant. Now, going back to the topic of vaccination and the surveillance systems and a quick response to these outbreaks, we also have to know how to identify measles. Measles is something that has been circulating considerably in the last couple of years. After 2016, when we achieved the elimination, we lost that in 2018, that regional status, when in Brazil and Venezuela, it started to circulate again. And we started to recover that measles-free status in 2024. We know that it's very communicable. We have to identify it, how it manifests itself, what the symptoms are, the signs, atypical cases as well, because we have immunization, or we don't have homogeneous, or if we don't have a homogeneous vaccination or immunization standards, then that can open the door to reemergence. It's very important for at the clinical level and other healthcare workers that they can identify it. It's also very important for us to learn more about it. We have Herminio Hernandez with us. He's going to speak to us shortly. Thank you very much for being here, for your presentation. And then Angela Gentil is going to talk about the importance of vaccines, what types of vaccines we have to immunize against measles, and some specific recommendations as well. That said, we hope that this webinar is going to be very helpful as our speakers address you from the laboratory level as well, and we'll talk about how best to respond to these outbreaks. But we want this webinar to cover these key aspects. Why? So that we can actually move toward recovering the non-communication of measles. There are always going to be some imported cases until it's fully eradicated, but until then, we have to update ourselves and rein in those cases that we do get, control them. That's what we're trying to do, and that's what we'll be doing during this immunization week. Last week, we were with the director of PAHO in Canada at the launching of a program there. And so it's very important for us to keep seeing how best to work on such a difficult virus as is measles. Sometimes people think it's a light thing. The symptoms have gone and they don't see the need to vaccinate themselves, but that's not the case. There's going to be a variation among countries. 11% to 20% in some cases is the level of hospitalization. And it's really hard to quantify something. Secondary infections give an immunological amnesia that can result from this, which is a vector, and Angela is going to be talking about that. And acute sclerosis that can subacute sclerosing panencephalitis, which can emerge a few years later. So it does have its repercussions, and we have to pay a lot of attention to how we're going to work on this to keep it from becoming endemic in the region, a sustained transmission level in the region. So, without further ado, I give the floor to our colleagues who are going to be addressing us. Thank you very much. See you soon.
Muchas gracias, Dr. Salas, por
Thank you,
esta
Dr. Salas,
introducción. Vamos a continuar con el programa. Le
for
doy
those
la
opening remarks. Now, moving
palabra
ahead
al doctor
with our
Álvaro
agenda,
Wittenberry,
we give the floor to
asistente
Dr.
en
Alvaro
resurgence,
Wittenberry
asimismo a la doctora Gloria Rey,
and Dr.
asistente
Gloria
y
Ray
dependiente de laboratorio. Por favor,
to
pueden
address the lab component of
pueden
this
dibujar
webinar.
sus preguntas en la
Feel
cajita
free
de
to
preguntas para luego
write your questions
considerarlas
in
por
the
los
chat
panelistas.
box
Adelante,
to
por
be
favor.
answered by the panelists. Let's start with the panelists. Proceed, please.
¿Me confirman si pueden ver?
Please confirm if you can see the presentation. Not yet. Now we can see it, but it's not in presentation mode.
Y a ver allí. Bien. Sí se ve, ¿no? Ahora sí, modo
Now you can see it, correct?
No, no aún.
Not quite. Not yet.
Tal vez un
There we
rato.
go.
Eso, perfecto.
Now it's in presentation mode.
La conexión está un poquito lenta. Esperemos
My
que
connection's a
mejore.
bit slow.
Ante
Hopefully that will
todo, muchas
improve.
gracias a todos por estar
So I'd like to thank
presentes.
everyone
Es
for
un
being
gusto
here. It's always a pleasure to
participando
be
en
with you and to take part
estas
in
reuniones. Y
these
en este caso,
meetings. And in
vamos a
this
comentarles
case,
sobre la situación
we'll be
de
talking
measles,
about
una
the
situación que
situation of
realmente nos
measles,
preocupa
which is
mucho.
one of grave concern
La
to
breve
us.
actualización
And I'll
y
give you a
reporte
brief
sobre measles
update
con respecto
and
a la
then give you
respuesta.
some information
Muy
regarding the
rápidamente,
response.
la
So I'll be
representación
quickly
regional
and talk about the
Gloria
regional
Rey nos va a hablar
measles
de
situation. Gloria Ray will
cómo
be
realizar
talking
las pruebas
about
de
how
laboratorio, un poco sobre la
to conduct
epidemiología
test,
molecular,
lab
también elementos
tests,
rápidos de la
molecular
respuesta,
biology,
puntos importantes
a
de la
few
respuesta
comments on
rápida
the
y por
response, the
supuesto
rapid
algunas
response,
consideraciones de cara
and
a
some
los eventos masivos, especialmente la cobertura
considerations
nacional.
regarding mass events.
En relación a la situación regional, no
As regards the
podemos
regional
empezar
situation,
sin mencionar las coberturas de
we would
vacunación.
be
Recordemos las coberturas de
remiss if we were not to
vacunación
talk
que si
about
bien
vaccine
mejoraron en los
coverage, although
últimos
it has been
años,
improving over the
todavía
last couple of
estamos
years.
lejos de
It's
ese
still far
95%
from the
que sabemos que
95%
tenemos que
that we
lograr
strive for.
a fin de
We know that
garantizar que
that's
no
what we have to
vayamos a
achieve to
tener
make sure that
grandes brotes de
there aren't
enfermedad.
going to be
Fíjense
large-scale
ustedes
breakouts,
que en el
outbreaks. Now, in
2024, que es
2024,
el último dato que tenemos
which is the
disponible,
last
según
available
INARME,
information we have at the regional level,
89% para la primera dosis y
89%
79% para la segunda dosis. ¿Qué
for the first
significa
dose
eso?
and
Que
79% for
de
the second dose. What does
1.5
this mean? It
millones de
means that
niños en América y
1.5 million children
Latinoamérica
in the
no
region of the
recibió
Americas did not receive
ninguna dosis de la vacuna
any dose of the
y que
vaccine,
1.3 millones de
and
niños
1.3
recibieron la misma
million
sin completar.
received
Entonces
an
todavía hay un buen
incomplete
número de niños muy
schedule.
importante que
That's
no
a
se están
large number of
inmunizando a
children that
través
aren't
de la vacuna.
benefiting from
En
this
este ánimo,
vaccine, this
vamos a dar una
immunization. Now, on this
información un poquito
screen,
sobre
we'll be
cómo está
talking a little
esa
bit about
transmisión en los países. Vemos que
transmission in
tenemos 13
countries. We have
países con
13
transmisión
countries
activa en
with
la
active
región.
transmission in
Muy
the
importante
region.
comentarlo, verlo
It's
allí.
very important to
Lamentablemente,
point that out.
muchos países
Unfortunately,
con
these are
brotes
many
y
countries
muchos de
with
estos países
outbreaks in many of these countries have sustained transmission over time. We can look at the United States, which has a high number going back to 2025. In the southern part of the country, Peru has large numbers close to Bolivia, Mexico, and pretty much all of the states of the country, as well as Guatemala, of its departments have sustained numbers. Canada, where there is still transmission in the country, Bolivia has a very low level of transmission, but still present in Santa Cruz mostly. Now, this slide is to show you that the trend of cases this year has risen sharply, 8 times more cases than we saw in 2025. Now, in 2025, we already had a 30 times increase compared to 2024. So, if we were to compare this year with 2024, which was a moderate transmission level, to put it some way, we're talking about more than 90 times more cases so far this year. This stems from the dynamic transmission mostly, but susceptible pockets and populations that haven't been sufficiently vaccinated, with some gaps in their immunity. On the right-hand side on that chart, you can see how countries are doing week by week, broken down by country. There's a considerable rise in transmission in Mexico. This rise is of concern in Guatemala, and of course, sustained transmission in some other countries, such as Canada and the US, and the one in Peru over the last couple of weeks. Now, look here, while there is a drop in reports of cases, notifications of cases over the last couple of weeks, we have to be careful here because we're still analyzing this with national authorities about what actually might have led to such an abrupt drop off in the number of cases. It's not really a normal epidemiological pattern that we're seeing here. Now, if we look at distribution by age, under 1 year of age, they usually have an incidence rate higher. That's the age group that isn't often vaccinated yet. And so that's why it's very important to start with 0 doses where there's active transmission among the recommendations that we have. And we see that transmission in underage children under 5 is still significant. However, in the region, given the dynamic of transmission that we are seeing up to 29 years of age, which can be of concern. And so, what's important here is for us to recall that depending on the epidemiological landscape, the responses are going to have to vary. Now, here, these charts are to talk to you about the risk of death by measles. It is not a light disease. It's one that can be quite severe, and there is a considerable risk of death in children under 1 year old and under 5, in which the rate is higher than other age groups, as you can see here in this chart on the left-hand side and on the right-hand side. That's just to remind everyone that while measles is a disease that mostly affects children under 5 years of age, under 10 even, regarding mortality, if we do have people in age groups of 50 years old, if they do get sick, the risk of death can be quite high as well. So it's a double pick under 1 year of age, and then lethality starts to drop off. Those you can see those who died, and here another peak spike at the 50 to 59 years of age. So we can't drop our guard with adults either, as they get older.
Gracias, Álvaro.
Gloria,
La
thank you.
siguiente
Alvaro,
diapositiva.
next slide, please.
Básicamente, en esta diapositiva,
Now, on
la
this
idea es
slide,
que podemos observar cuáles son los tipos de
you can
muestras que
see
se deben
what
obtener en
the
cada caso de
samples that should
susceptibles a
be
la vacuna.
taken from each suspected
En
case
todo
of
caso, se debe recolectar
measles.
siempre una muestra de sangre
There should always be a blood
evaluar una
sample
muestra
taken, as
respiratoria que
well
puede
as a
ser un hisopado
respiratory
nasal,
sample, which
hisopado
could be a
faríngeo, un
nasal
hisopado
swab,
y también es deseable obtener una muestra de orina.
and
Todo
also
esto
a
sencillamente
urine
para
specimen.
facilitar la
All of this
realización
to
de las pruebas en
facilitate
laboratorio y tener una
the
oportuna
lab tests that
confirmación de
need to be
ambos de los
made to
casos. Para
confirm the
cada una de
cases
estas
on a
muestras
timely
hay un
basis. For
tiempo de
each one of these
obtención
samples, there
y,
is a time within
número dos,
which
insistió, la
they should be
vigilancia desde el
taken
primer contacto
from
con la
the first
institución de
contact
salud,
with
pero
the
que
health
pueden ir
institution,
hasta
but
30
that can
días
go up
después
until
del
30
inicio del
days
exantema
after
para el
the
caso de la sangre o
onset,
hasta 14 días
day
después
of
del inicio del
rash
exantema para la muestra
onset,
respiratoria y hasta 10 días para
and
la
up
muestra
to
de orina.
10 days for the
Siguiente.
urine sample. Next.
En esta diapositiva
Now, on
podemos
this
ver lo que
slide,
es la red
we can
regional de
see
laboratorios, la
the regional
capacidad y
network of labs
la
and the
estructura.
capacity,
Esta
the
red está
structure that
formada
exists
por
of
un
this network
laboratorio
made
mundial
up by
especializado en el
specialized
rojo, dos laboratorios de
labs in
referencia
red, reference
en
labs
verdes
in
y
green,
21
and
laboratorios
21
nacionales.
national
Pero al mismo
labs.
tiempo hay algunos
And at the
países
same
que
time, there are
tienen
some
laboratorios
countries that have
subnacionales. En total
subnational
tenemos cerca de
labs,
114
114, in
laboratorios
fact,
alrededor de la región que
throughout the
realizan estas
region
pruebas.
that conduct
En la
these
derecha
tests.
pueden
On the
ver ustedes la
right-hand side,
capacidad
you can
diagnóstica,
see the
que
diagnostic
básicamente se
capacity,
fundamenta en pruebas
which is
serológicas para la
based on
detección de
a
anticuerpos
serological test to
IgG
detect
y
antibodies
pruebas virológicas que
and
van desde el
virological
cultivo
tests,
viral hasta las muestras, hasta las pruebas de moleculares con
as well as
PCR y
molecular tests
secuenciación.
with the
Siguiente.
sequencing and genotyping,
Esta
RT-PCR.
lámina y fundamentalmente la lámina de la izquierda
Now, on the left-hand
muestra los
side,
marcadores
what we can see
biológicos de
are
la
the biological
infección,
markers
realmente
of the
sarampión. En el eje de
infection
las X se ilustran
of
los días.
the
Notar que el
measles
día que
virus. Now, we
inicia el
look
exantema
at the
se
day in
reconoce
which a
como el
rash
día
emerged.
cero.
That
Es
is
muy
day
importante, por
zero
tanto,
when it
conocer
emerged. It's
la
very important
evidencia de
to
cuándo inicia
have
el
evidence of
exantema en el
when
caso.
the
Y
rash
también
starts.
recordar
And it's
que
also very
realmente
important
lo que
to
esperamos es que la
go back.
fiebre se presente
The
antes del
fever
exantema.
normally
Esta
would
fiebre se puede
present
presentar hasta
before
3 días
the
antes,
rash,
es por eso que
up to
aparecen
three
aquí los
days
números en
prior.
negativos.
And that's why I
En
have
el
these
eje de la
negative
Y se
numbers.
observa la proporción de
On the other
resultados
axis, we
positivos
see
según los
the
marcadores
proportion of
biológicos de la
positive
infección. Pero
response according
fíjense
to the
ustedes que para el
markers.
día
But if
cero,
you look
la
on
mayor
day
positividad
zero,
la tienen
the
las pruebas de
higher level
detección
of
del epitelio
positivity
viral y el cultivo viral. En pocas
is
palabras,
seen in the
está
viral
en
culture
los momentos más
within
cercanos al inicio del
as we
exantema,
get
son
closest to
mucho
the
más
beginning of the
eficientes
rash.
en detectar el
It's
RNA
much
viral
easier
en la
to
reacción
detect
alérgica.
the RNA,
Esta
the viral
positividad
RNA.
va
Now,
decayendo
that
con el
positivity
tiempo, pero por el contrario, se observa
changes
que la
over time,
tasa de
but we'll usually
anticuerpos y los
see
primeros
um,
anticuerpos que
the
se
first
producen son
antibodies
los
that are
tipo
produced
IgM
are
y estos anticuerpos,
IgM,
la
and these
positividad
antibodies, the
aumentando
positivity
día a día y
increases day
alcanza para
by
el
day,
IgM cerca de un
and
100% para
up
el
to
día 4 o
100% of
5.
IgM by
Si
day 4
obtenemos
or
muestras
5. Now, if
después
we
de este
obtain
tiempo, con
samples after
certeza
that
tenemos
time,
una detección de
certainly
anticuerpos
we
IgM que
have
nos va a permitir clasificar el
antibodies,
caso.
which will enable
A
us
la
to
derecha se
identify
observan
the
los
case on the
criterios de
right-hand
confirmación
side.
por
We see the
laboratorio.
criteria of
Hay varios
confirmation at labs.
criterios
There are a
listados,
number of
pero el
criteria
fundamental
listed here,
recordar
but
que
it's very
una
important
sola
to
prueba
recall
positiva
that only
es
one positive
suficiente para
result
confirmar un caso
suffices
con
to
una infección
confirm
reciente
a
por
case as a
sarampión. No
recent
se requiere
infection by
realizar toda la
measles. You don't
batería
have
de
to
pruebas que están
do the whole
disponibles en el
battery of tests that are
laboratorio.
available in the
La
laboratory.
siguiente.
Next, please.
Y a continuación, lo que
Next.
podemos observar es
What we can
la
observe
distribución
here
mundial de
is
los
the world
genotipos.
distribution of
Es importante
genotypes.
recordar
It's
que
very
el virus
important
del
to
sarampión es un virus
recall that
RNA
this is an
rectificativo,
RNI
es decir, solamente hay un
monotypical
serotipo. Sin
virus. There's only
embargo,
one
tiene algunas
serotype.
variaciones
However, there
genéticas.
are some
Estas
genetic
variaciones van a
variations, and these
permitir
variations
identificarse
enable us to
24
classify
genotipos
them in
diferentes.
24 different
Haciendo la
genotypes.
secuenciación
Now,
y
if
la
we do the
documentación de los
sequencing and the
genotipos
documentation
virales, lo
of
que
the
vemos en
viral
el mapa es que
genotypes, so
los
what we see
países
on
que
the
están en
map is that
color
the countries
amarillo
that
son
are
los
in
países que
yellow
han
are
reportado
those
brotes de
that have
sarampión
reported
durante los últimos
outbreaks
12
during the
meses.
last 12
Y el
months,
círculo son
and
los
the
países que
circle
reportan genotipos
are those countries
asociados a
that
esos
report genotypes
brotes de
associated
sarampión.
with measles
Notar
outbreaks.
que el
Now,
genotipo
look
B3
here
aparece en
that
color naranja,
in
naranja
orange,
y el genotipo de
it's
8 en color
B3
azul.
and 8 in blue.
Siguiente.
Those are the genotypes. Next.
Y en esta diapositiva
On this
sencillamente van a ver
slide,
las secuencias que han
we
sido
see the
reportadas por países
sequencing
en la región de
reported by
las
countries of the
Américas en
region of
este
the
periodo
Americas during
2024
the
hasta hace un
2024
par de semanas del
period up until just a
2026.
few weeks
Durante
into
este periodo se han
2026. During this
notificado a
period,
MINS, que es la base global de
there's
reporte
a
de
global network
secuencias
of reporting
que
sequences
soporta la OMS.
that is
Los
supported
países
by
han reportado
WHO, and countries have reported
3.469
uh,
secuencias genéticas del virus, pero básicamente
3,469
corresponden
sequences of the
estas
virus,
secuencias a
identifying
dos genotipos, el genotipo
the virus,
B3,
B3
nuevamente en
mostly
naranja, y el
in
genotipo
orange, and
E8 en azul. A
B8
la
in
derecha ven
blue
ustedes la
were the primary
distribución,
genotypes. Now you
digamos,
can see the
la
distribution on the right-hand
proporción de
side
esas
and the
secuencias a
proportion of
través del
synthesis these sequences over time. The largest proportion has been, without a doubt, is that of D 8.
Y adentrándonos un poquito más en
Now,
esta parte molecular,
delving a
en la
bit more
parte
into the molecular
superior de lo
aspect,
que es la
on the
curva
upper part, you can see the
epidemiológica de la
epidemiological
distribución de la
curve and the
resurgencia,
distribution of the
ustedes
B3
aprecian
genotype.
allí en el
Now,
eje
you
de
can
la
see
columna,
here
digamos, las semanas epidemiológicas,
in the
pero ven también
epidemiological
que hay una
week
gran
on the
variabilidad
vertical
de
axis, and
colores.
we see a
Cada
variability
color
of colors.
representa una
There, each
secuencia
core
genética
represents a
distinta
genetic
y se
sequence, a different
asigna
genetic
un número,
sequence, and
entonces
assigned
se
to it is a
reconoce como
number.
D, S y
So
D.
we recognize
Y
it
ustedes ven
as
allí que hay múltiples
DSED.
colores,
Now you
quiere
can see
decir
a
que
host of
realmente
colors.
son
That means
diferentes
that they
secuencias
are
genéticas las
different
que se han
genetic
encontrado
sequences
a
that
través
have
del
been
tiempo.
found over
Notan
time.
que
Now,
definitivamente hay una gran
you will
variabilidad
note
y
that there's a great
distribución que ven en
variability
la
in the
parte
distribution
superior
that you see
gráficas
on the
es
lower
muy diferente, no
part,
hay
very
algún
different.
color que se
There is
mantenga a
no
través del
color
tiempo.
that
Esto básicamente en cuanto a las
is
secuencias
sustained
del
over
gen
time
V3.
regarding the
Siguiente.
B3
Y
sequence.
esta es de forma
Next,
similar la
now,
curva
similarly,
epidemiológica, pero
this is the
para la secuenciación
epidemiological
en
curve
V8.
for
15
D8
países han reportado
sequences. 15 countries have reported
4.985 secuencias solo del genotipo E8.
2,985 sequences
Entonces
just
noten
for
ustedes aquí, a
D8. But
diferencia del
look
anterior,
here, unlike the
hay un
prior
color que
example, there is a color
permanece
that
durante
does
este periodo.
hold steady
Básicamente
throughout
ese
the
color
whole
era la
period.
secuencia
That
DCID 9171
is
y la que estaba
9171,
asociada con la gran cantidad de
that which is
casos
associated with the
participación en
most
el
outbreaks that we've seen
Sin
in the
embargo, ustedes
region.
pueden ver
However,
también que hay
you can also see
colores
that there
azules
are
mucho más
some
suaves.
blue
Como
colors,
ustedes ven,
a
aquí
lighter
han
blue,
reportado algunas secuencias con uno o dos nucleótidos de
with
diferencia
one
comparado con la
or two
secuencia
nucleotides that are different from that 9171. Now, it's very important to say that the correlation of the genetic data with the
epidemiológica
epidemiological data that we have are
significativa
key for us to better understand these
porque este cambio
findings,
genético
because these
puede ser
genetic changes can be the result of
o está
an
relacionado
evolution of the
con la
virus
importación
or
del virus. Vuelvo a
uh,
repetir.
Gracias, gracias, Gloria.
thank you, Gloria.
Muy bien, entonces
Very
rápidamente
well.
vamos a revisar
Now,
elementos
quickly,
claves de la
we're going to look at
respuesta
some
que
key
son
aspects of the
aspectos que no
response,
debemos olvidar. El sarampión es
things
muy
that we cannot
contagioso,
overlook,
así
cannot
que vamos a
forget.
muy rápido.
Measles spreads very
El sarampión
quickly.
tiene un periodo de transmisibilidad
There's a
más o menos
transmission
amplio,
period that's
entonces,
quite broad,
además de que tiene ciertas
and
facilidades
there are
para
certain
poder ser
facilities that it
transmisible,
has
¿no? En
as far as
permanecer
transmission.
infeccioso, en permanecer
The
infectante
fact that a
durante
person can be
años,
infectious, or
miles de
rather,
años,
it can
durante
remain
décadas.
infectious in the
Entonces,
air for a couple of
importante
hours. So it's very
considerar que las
important to
actividades de
bear in
control
mind that
van a ser inmediatas.
prevention and control
Siguiendo con
activities
tema,
need
por
to be
ejemplo, el día
undertaken.
cero, con
Now, if we
la
look at day
detección e
0,
identificación de
with
un
the
caso
infection
sospechoso,
identification of a
obviamente
suspected
tenemos que
case,
comenzar las
suspect case, well,
actividades
we
de
have to start
investigación, de
the
confirmación de caso lo antes
investigation, the
posible,
confirmation of the case as
así como
soon as
las acciones
possible, as well
de
as
control
those
inmediato para
actions of
todas
immediate
estas medidas de
control
vacunación selectiva que van a
for
ser
selective
la vacunación
vaccination
de bloqueo,
measures,
la vacunación de barrido,
blocking vaccine
dependiendo de
or
cómo esté ese
sweeping
escenario.
vaccine according to the
Mientras
situation.
más tiempo demoremos,
Now, the longer we
más
wait,
complejo es el
the more
escenario
complex
y
the
posiblemente
scenario becomes,
mayor
and
el
possibly
gasto
the
y la
greater the
inversión en
expense and
recursos
the
que vamos a tener que
investment,
realizar.
expense of
En Brasil, por
resources
ejemplo, en esta
that
prueba
will
del
have to be
año
made. In Brazil, if we go back to 2018, 2020, and those
2020
outbreaks,
¿no?
we
Para
learned a few
esto
lessons. The country had to
intervino
intervene and
108 millones
invest
de dólares para
$108
responder
million
a estos brotes,
to respond,
aproximadamente $3.000 por caso.
nearly
Entonces, cada
$3,000
día
per
que
case.
perdemos
So
en
every day
intervención,
we
en
lose,
empezar las
that we don't
actividades
intervene and
de
start the
investigación y luego control,
research or
eso
investigation and
va a
control
llevar un
measures,
mayor
that is
gasto,
going
va a
to
llevar una
lead to
mayor
a higher
transmisión
expense,
y nos va a
more
llevar
transmission,
posiblemente a mayores
and
riesgos para la
possibly
salud de la
greater
población.
risk for the
Entonces, muy
population.
importante considerar
It is very important
rápidamente
to
este
consider the
instrumento que para
possibility of
nosotros es muy
establishing the
conocido,
command
el tiempo
center,
de
the
prueba,
incident
¿no?
command center,
24,
within the
72 horas
first
para que
24 to
coordinen sus
72
medidas de
hours so that they
prevención y
can
las
coordinate
detecten.
vaccination, surveillance,
Ustedes
and
saben que
laboratory.
los
You
ministerios
know
de
very
salud
well that
no
within
necesariamente
ministries of
todos
health,
sus equipos
not
están
necessarily all
integrados.
these teams
Hoy
have
podemos
been
identificar
integrated,
casos
and they
específicos
can
en
face
países
difficulties or
donde
challenges
el
for
gobierno
coordination.
facilite
So
la
having a
coordinación
clear
para
incident
poder
command that will
la
facilitate
activación de
this
los
is
equipos de
essential.
respuesta
Then
rápida, iniciar
activating
estas
rapid
acciones en las
response
primeras
teams and
72
beginning
horas
the
de los
actions
primeros 3 días
within
de
the first
epidemia,
72 hours
¿no?
during the first
La
3 days is
vacunación que debe
essential. Then immunization, vaccination that has to be implemented, be it blocking, sweeping, depending on the epidemiological situation, is extremely important. If we have one isolated case, perhaps a blocking vaccination is sufficient. But if we're having a larger number of cases, and if we see that this vaccination system is not being effective in order to avoid the transmission, that we have to expand activities, and we will have no doubt to consider activities such as a change in schedules, flexible schedules during the vaccination times, including weekends. Early detection is very important. It is very important that health professionals and health staff in general, as well as the population, should be duly informed, and always to use epidemiological information to guide the response actions. There are some recommendations that recently came out by PAHO, recommendations offered by the Advisory Strategic Group on Immunizations in the region regarding the use of vaccines. We have this recommendation on the use of the vaccine SRP, Leningrad, Zagreb, and the SRP or rubella, Geraldine, or for vaccination to adolescents and adults, which is this other preferred vaccine. Obviously, we prefer SRP, Geraldine, starting at the age of 10. However, if we do not have any of these vaccines and the one available is SRP, Leningrad, Zagreb, MMR, Leningrad, Zagreb, that is the one that we have to use in order to vaccinate the different groups, those that we identify as being impacted by the outbreak. So countries can see the use of this vaccine in order to vaccinate over the age of 10. It is very important that the decision-making bodies in countries should perform an appraisal and an evaluation ahead of this, not to wait for the outbreak in order to have a recommendation provided that will facilitate the activity of local teams. Then regarding recommendations for FIFA for the World Cup, we wanted to share with you some considerations before travel. All travelers ages 6 months and older, because we know that the Cup is going to take place in 3 countries that are very active in the transmission of measles. These are active countries, so it is very important that all people, as of the age of 6 months, be vaccinated, that they will receive 1 dose if they do not have the full schedule. If they were to have the full schedule, and this can be tested with a vaccination certificate, so there's no problem. But if they don't have the complete schedule, if they have any doubts about having the full schedule, it is very important that they get a dose. Ideally, this should be given preferably 2 weeks before traveling, but this does not mean that if you have less than 2 weeks before the travel that you don't get the vaccine. No, we need to get the vaccine in any case. It is very important to consider this. Now, regarding health authorities, it is also recommended and they're advised to inform travelers before departure about the signs and symptoms of measles, for the population to self-report when showing some of these symptoms and signs of measles, fever, rash, cough, runny nose, conjunctivitis, etc., or a rash. Regarding during travel, if we were to have the presence of symptoms or a sign of the disease, it is important that the travelers look for and seek medical attention, and they will only do that if they're informed about what these signs and symptoms are. Obviously, to avoid contact with other people, avoid this close contact for 7 days from onset of rash. That is to say, as soon as we see the onset of a fever and rash, and up to 7 days after that, we consider 7 days because we might be suspecting not only measles but also rubella. So these are 2 very important diseases regarding our elimination strategies. So it is very important that during this period of time they kept isolated and that they wear a mask to try to reduce the risk of transmission, and obviously to remain at your place of accommodation wherever the people are lodged, except to visit the doctor during this period, and to avoid public places. And if the travelers suspect that they have contracted the disease when they go back to their countries of origin, then they should also stay at home in their home country and to contact their health services and inform their doctor about travel. I believe that these are the main topics and the main messages that we wanted to share on our part. So let me give you the floor back, Pamela.
Muchísimas gracias.
Thank you very much. And let us now move on to the rest of the agenda for today. And for the following presentation, we have Dr. Herminio Hernandez, who will be talking about clinical aspects of measles. Dr. Hernandez is a pediatrician, adjunct pediatrician in the Cayetano Heredia National Hospital in Lima, Peru, as well as a professor emeritus in the Cayetano Heredia Peruvian University. And he's a member of the regional Commission on Measles and Rubella, headed by Dr. John Andrews. So I now give the floor to Dr. Herminio Hernandez, without reminding you that you can start including all your questions in the Q&A. Some of the questions will be answered as we move on in the presentation in this Q&A, and others will be answered in the chat. So please, Dr. Hernandez, please proceed. Good morning, everyone. Can I share my presentation now? Yes, please go ahead, Herminio. Thank you very much, Álvaro.
Estamos, creo que en pantalla completa.
I believe that we're not showing the full screen. That's good.
Muy bien, entonces
Very good.
vamos a hablar
So
de
let us talk about clinical aspects of a disease that has already been mentioned, is viral, highly transmissible, and its presentation, classical presentation, is 3 stages, a succession of 3 stages. Each one lasts from 3 to 5 days. We have the prodromes, we have the outbreak, and dry or desquamation. So this is a disease that is acquired, as you know very well, through respiratory secretions, aerosols that are emitted when coughing, when the sick person coughs. So this will lead to an infection of the entire lymphatic tissue in the pharynx, and that leads to the first reaction that will invade the whole lymphatic system in the whole body, and this will lead to a second virus infection that will invade lungs, digestive system, and the urinary tract. And as a result of this one, it leads to the symptoms, and then the patient coughs, aerosols, and then this becomes contagious. And so you have 2 pictures of the type of outbreak during the second stage, that is to say, during the stage of the outbreak. Now, during current times, we should consider 2 presentation forms: the classical typical presentation and then modified measles. The classical presentation is where we see a repetition of these periods of 3 to 5 days of prodromes, outbreaks, and dry. So in the scheme, we can see, and here I'm pointing out the beginning of the outbreak. And everything that comes before this is the prodrome period, where we have the fever. The patient is usually very symptomatic, very committed regarding the general situation, has a cough, rhino secretion, and conjunctivitis. And something that comes before this is what we call the COVID and the mucus, in this case, the oral mucosa. And in the lower morals, we have the erythematose reaction. We have these white dots, and this is what is called the Koplik dots or stains. And these are Koplik stains, and here on the left you can see the white dots, which is precisely, again, this Koplik. And it can be described as an erythema, where we see like salt grains. This, as we just saw on the graph, comes before the beginning of the outbreak. And then we have the outbreak itself. The outbreak itself, with this classic form with the complex spots, will be generalized usually on the third day. The first day, the outbreak is seen on the face and the neck. The second day, the trunk. And on the third day, the outbreak is extended to the whole body. So this evolution is typical of measles, and it is very helpful, particularly when we have the preceding prodrome stage and a presence of the outbreak itself. This is an erythema, as you can see, very clear, very evident when you have this skin that is white. And with the darker skin, this can be seen less. So we see that this moves forward, and during the third day, there's still fever present, and then the fever drops. So this is where the third phase begins, that is to say, the dry phase or convalescence. So after the third day of the outbreak, if the patient has a reemergence of the fever, then we can suspect that the patient might have a complication. And during the third period or the third phase, where we had these lesions in the skin, then we have these dark maculas, as you can see on the left-hand side. And particularly in children, malnourished children, and people with compromised immunity, they can have a significant desquamation in the body. The serious problem with measles is that it compromises the cell immunosuppression, but also moral. This is known as the immune amnesia, because it brings down the levels of lymphocytes, particularly CD4, and also there's a drop in pre-existent antibodies. So this can be seen in this study that I had the possibility of learning about it, because it was a thesis that was done by Tamagido, a student, several years ago. So this student followed this and located 25 children with positive tuberculin that developed measles, 13 of them without complications and 12 with complications. And they were subjected to skin tests every week. And we were able to see how, in fact, those who were positive, all of them turned, as you can see, delayed the hypersensitivity. They all became energetic, and then we saw the emergence of the response to tuberculin, which was a bit later when the children had complications. Well, this is a very clear test, how they turn. And on response that we have from the point of view of the immune response. In the upper chart, and this is, I'm pointing at this, so you can see this immune suppression, this dark line, which shows the level of the lymphocytes, the lymphocyte count that drops during the acute stage of the disease. And it will recover after 3 to 5 weeks. And we say dual because simultaneously there is an immune response of antibodies to be defended against the infection. Now, this immunosuppression, together with the disruption of the skin surfaces, are those that have to see with the possibility of complications. The most feared complication and most frequent complication is pneumonia. So pneumonia is the complication that can lead to fatalities, and it can happen because of a damage caused by the virus, and it's called giant cell pneumonia or pneumonia. This is the proper name, but it could also be because of bacterial complications or both. The measles virus and the bacteria that could be a strep or staphylococcus or pneumococcus. Obviously, younger children and older adults, pregnant women, and immunosuppressed individuals face the risk of having this complication, like giant cell pneumonia. As you can see on the right-hand picture, you see this X-ray, and obviously we have to weigh the possibility of using antibiotics. Then another complication that is also frequent is the presence of diarrhea, and this might have to do with the possibility of compromising the immunity. We have lesions in the cornea, which exceptionally could lead to blindness. A complication that cannot be neglected is otitis media, and death. Death could be caused because of these complications, and those that I will mention regarding encephalitis. And death could be caused because of pneumonia or because of encephalitis. And this could be between 1% or 10%, depending on the host that it comes with measles. Malnutrition is a consequence. Or it could also lead, if it is pre-existent, to severity of the disease. The other complications, as you can see on this slide, are less frequent when compared to the previous ones, and these are in post-infectious encephalitis or measles inclusion body encephalitis, and as has already been mentioned, it could also lead to subacute sclerosing panencephalitis, which in fact is very exceptional. We rarely see it, but if developed, and this happens 7 to 10 years after measles, because of the persistence of the virus in the lymph tissue, could lead to death because of the severity of this complication. Now, in connection with the nutritional situation, it is said that there is a bidirectional relation, because if there's a prior malnutrition, it contributes to the severity of the complications. But also, the complications themselves could lead to malnutrition because of the effect of the infections. So this is the number of cases of an outbreak in Germany, where 115 children in 2006 throughout Germany needed to be hospitalized. And here we see that the most frequent complication was pneumonia. Now, in this series, in fact, they were able to get 96 histories. It is pointed out that 2 children died because of encephalitis, because of body inclusion, months after having been hospitalized because of pneumonia. Then the severity of measles that we see in infants and adults, malnourished, particularly if they have hypovitaminosis A, conditions of immunosuppression. Pregnancy is another group, a special group of high risk. If for some reason any one of these populations have never been exposed, this will lead us to a very high fatality level, as was pointed out in the historic description of measles. The measles virus is not teratogenic. The pregnant woman can have an infection that could lead to fetal death, can be a delaying growth or premature delivery, complications in the mother itself, such as pneumonia, usually 2 or 3 times more frequent than in other groups, and therefore maternal death. We've already mentioned previously the classical form. So let us share with you another form that has to be considered nowadays, which is a form that does not lead to infection. It is attenuated. It happens in people with a partial immunity, those who received 1 dose or were immunized years before, or received immunoglobulin or receptors. The clinical manifestations usually follow the same sequence, but they're milder. Some symptoms or signs might be absent. The incubation period is slightly longer. The customary period is 7 to 10 days, and here it might be between 2 and 3 weeks. The complications are not frequent, but this is a big but, is that this is a source of infection, and this has already been described many years ago by Krugman in the text on infectious diseases during childhood. Let me share with you a case, and I had the opportunity to see this case, to follow this case. In 2019, and in 2018, in fact, Peru had a significant number of cases as a result of an outbreak that, strangely enough, began in Puno. Well, this is a first day she showed a fever, and didn't have any cup, no conjunctivitis. And so on the third day, she shows this generalized outbreak. And on the fourth day that I had the possibility of seeing the girl was doing much better. The outbreak was waning. These are pictures taken by the mother, and obviously she authorized us to use these pictures for any training, medical training. And when I see this girl on the fourth day, I told myself this is not measles. But then I thought, except that maybe the mother had measles. And in fact, that is what happened. The mother had measles when she was 6 years old. And when we saw this girl, she already had a positive PCR. So there was no doubt about it. The mother gave her passive immunity because she had the disease when she was a child, and also because she had been immunized, because in 2019, after the 2018 outbreak in the country, they really had a significant national campaign against measles. And here you see the epidemiological contact. This girl fell from bed and she went to a clinic, and on one side, she was together with a Peruvian coming back from Spain who brought the measles with her. So this girl really had the epidemiological background, which is very important. She was showing a positive PCR that was documented, but she obviously was not showing the typical picture, but the modified measles picture. So this is a collection of cases from Spain, where what we can see is that we can see modified measles and classical measles in those that are not vaccinated, in those that have one dose, or those that have 2 doses of the vaccine. Strangely enough, to the extent that you have more doses, it is almost half and half of cases with the 2 presentation forms. The diagnosis must have a clinical basis, epidemiological basis, serology, and cultures. This has already been mentioned by Gloria in the previous presentation. And for the classical case, the sequence of 3 stages, prodromes, spots, and dry, with 3 to 5 days duration, and to once again consider the possibility of having modified measles. We have to remember that the epidemiological side of it, the contact with travelers, endemic areas, or outbreaks, is essential for the diagnosis, as well as the possibility of travel. The serological part of it and the culture are extremely necessary in order to meet the 4 areas of the diagnosis. Obviously, we have other outbreaks that have outbreaks and fever. Therefore, it is necessary to take these into account in the differential diagnosis. Rubella is a generalized outbreak during the first day, and it disappears on day 3. It almost no prodromes. It doesn't show a lot of symptomatology. But the main concern with rubella is that the infection in a pregnant woman can lead to have malformations in the central nervous system, in the eyes, in the heart, and others that are known as the congenital rubella syndrome. And here you have the comparison. To the left, you see rubella puntiform, not very erythematosus, such as measles outbreak, that is defined as morbidiform. And then we have infections because of strep, pharyngitis, or impetigo. Simultaneously, as you can see on the right-hand side, together with the infection, we have the outbreak, and we have a high fever. We have an outbreak that is central, and it is one that, as described, and it is said, and I've seen this, that when you touch the skin of the outbreak, is as if you were touching the surface of this tongue that you see. And typically, after 3 to 5 days of an outbreak, or this picture of a scarlet fever, you have a very special desquamation in your feet and your hands. The issue is that this is a bacterial infection that needs antibiotics, penicillin, in order to avoid post-strep complications. And another viral infection, infectious mono, sometimes can have an outbreak. Typically, we have to see the pneumochrome and to see the atypical lymphocytes that are different from the normal lymphocytes. And there's a very special outbreak, very peculiar outbreak. And this is infants 6 months old, a year and a half, where they show a very high fever, 39, 40, 3-4 days. And as you can see graphically, the fever drops. And as soon as the fever drops, we have a generalized outbreak that can last 8 or 12 hours or up to 3 days. And because of the presentation and in the fever dropping, then we see the outbreak that is known as sudden exanthema. It is a disease and it is produced by human herpes. Now, enterovirus can sometimes have a biphase of malaise, digestive problems, and we see that these manifestations start waning, and after 1 or 2 days of having no symptoms, which is known as the biphasic curve, and sometimes it can show compromising in the central nervous system, showing stiff neck, and sometimes it can show outbreaks. So we're talking about infections caused by enterovirus. Now, parvovirus B19 have a different presentation, which is relatively characteristic. It is an outbreak that is peripheral. Here you have the forearm with the characteristic outbreak. But what is typical is that these are children, older children or teenagers, where we have this erythema that is quite characteristic in both cheeks. We are talking about the fifth disease caused by parvovirus. Parvovirus can be similar to rubella or to measles. And if we wanted to see the differences between these, flavivirus have an absence of respiratory manifestations, and measles does have it. And the difference is that measles does not have these reactions, and these flavivirus do have them. So when we're faced with an outbreak that, as you can see here on this image, it is a mirror outbreak, one over the other one, we should always think that we're dealing with multiform erythema. And we have to look from what is known as these lesions, that is to say, in the bull, like shooting. And this is symmetrical outbreak with a sign. And so it is the erythema multiform minor erythema. The problem is that this type of an outbreak with these sign can be given because of certain bacterial reactions in this what is called the rosette. So one is faced with the situation of having to decide, is this because of the disease or because of the treatment that I'm giving the patient? And finally, when am I to suspect the presence of measles in a child or adult with fever or exanthema, as perhaps having been in contact with travelers or having traveled in case they have outbreaks or cases of measles? For us here in the country, an outbreak after having visited Puno, when the exanthema or the outbreak is preceded by prodromes 3 to 4 days before. When we have an outbreak and the one who is suffering this has an absence of vaccination or has only received one dose some years ago, and we must not forget the other possibility that we should also consider the possibility of having modified measles when we have the clinical picture to confirm this. Thank you very much.
Muchísimas gracias, Dr. Herminio Hernández.
Thank you very much, Dr.
Hay varias preguntas
Herminio Hernandez. There are a number of questions that have been placed in the chat. One has actually been answered by the prior panelists, and then we will put the other questions in the Q&A chat. We give the floor to Dr. Angela Gentile, who is a pediatric infectious disease specialist, epidemiologist, head of the Department of Epidemiology, the Ricardo Gutierrez Children's Hospital in Buenos Aires, Argentina. She's a member of the National Advisory Committee of Ethics and Research of the Argentinian Health Ministry and former chair of the Argentinian Pediatrics Association, as well as having been the president of the Latin American Infectology and Pediatric Association in the area of infectology. She's a professor of infectology in the Southern University of Buenos Aires, and she's also on our committee on measles and rubella. Thank you very much, Pamela, for that introduction. It's a real pleasure for me to be here with you and sharing this excellent webinar with you and sharing our concerns with you as well, regarding this challenge we face of the regional outbreaks of measles. The whole region is behind this, making efforts to address this situation. I'm going to put my presentation up on the screen. Tell me when you can see it. Can you see the image now?
Sí, Ángela, la estamos viendo completa.
Yes, we do see it.
Modo presentación.
Thank you very much, Pamela. Over the next 20 minutes, we're going to talk about how we are facing down this threat, tackling this threat, because after having heard from Herminio, this is a highly transmittable disease in which the virus can be the last 35 cases we had in Argentina between an adult undergoing a test that had measles that wasn't diagnosed, leaves the area, and then an hour and a half later, someone that has an x-ray of the thorax and that person has measles. We saw that. I'm talking about the Buenos Aires Children's Hospital. We saw that. So how do we face this challenge, which is of concern to us? Clearly, first and foremost, you have to vaccinate. And that's what we're going to be talking about here today. What are the characteristics of the vaccine? What are the indications of use, efficacy, and safety, precautions, contraindications, and some of the situations that need to be borne in mind during vaccination. Now, the impact of vaccination. Since 1964, 54 million deaths have been avoided, and also infants under 1 year of age, lives saved. So you can see the success and the positive impact of the measles. This is from 2024, a Lancet article, which underscores the importance of vaccination. Now, the licensing of the vaccine came in 1963, and there was a need that was for a single dose, and in 1889 it became necessary to add a second dose, and in 2000 we started to see the elimination of measles. But the point here is that you do need two doses. And the very important point here is what we're going to see now, which are the characteristics or the traits of the vaccine. This is an attenuated triple viral vaccine, the MMR, as it's known. These are live viruses, attenuated, counterindicated in the case of a pregnancy or anyone who is immunocompromised, even though we know that not all immunocompromised people are the same. Some have a greater risk than others. And then we're going to know when we see the indications, we're going to see some key aspects on that. But the attenuated vaccine, we have to look at those groups that should not receive that vaccine. Now we know about the need to not freeze it, to conserve it, and the multi-dose flask. I want to stress that because I'm going to talk about timorsol, which is a conservant for multi-dose flasks, but it did give rise to some controversy. And so we have to be very clear that in a multi-dose flask that uses this additive to preserve it is not risky. There's vast experience pointing to that. Now, when we look at the immunogenicity and effectiveness, we see that there's a high level of zero conversion, very similar to a natural infection. One dose, that is 95%, is 95% effective. Two doses, between 97 and 98% effective. Now, there are two key points here I want to stress. The first is that when I have only one dose, there might be a primary vaccination failure of up to 5%. Let's look at this closer. We know that we have a 5% primary failure rate, but we also know that the coverage of vaccination is not sufficient for us to address such a grave respiratory disease. Now I have the first dose. That is, 11% of the cohort is left unvaccinated, but I have a primary phase of 5%. It can be even higher. And so I want you to understand that per cohort, there's a susceptibility that is accumulative. And so we have to look at that primary failure rate and understand that the second dose, at the time it's given, it's not a booster, but it's to cover that primary failure and to make it possible to fully avail ourselves and reap the benefits of vaccination. Now, this is a means of simplifying it in graphic terms. From 12 to 18 months of age, that second dose is very important that it be given in an advanced way. First dose for protection, then the second dose. Now, there's much to be done, and it's very important for us to underscore that there need to be two doses administered starting 1 year of age. Now, there can be second vaccination failure. It's not just a primary failure that can happen. We're now looking at different evidence, and we see that failure can be covered with the second dose, but there is a 0.2%, very low percentage of secondary failure. In a webinar of updating the information such as this, we know that we can start with the beginning of the disease. It may be attenuated or modified, and generally speaking, most cases of measles are of those people who have not been vaccinated, but it's also very important for us to stress this, precisely because there can be a case that arises under these circumstances. So, secondary failure in a case of a person that had already been immunized. People have usually received their second dose if they're older, but that's not the case of the outbreaks, because we look at the current situation, we look at the bulk of the cases, it's on or befalls those people who are mostly not vaccinated. Now, if we look at use indications, here's the other important point I wanted to stress, and that is the need for the first dose and then the second dose to be in year 2 of life. That is, it's important to receive that second dose and to administer it rather at that age. Now we're talking about 2 MMR triple viral doses to say that we actually have a full application, full scheme or schedule. Now, the key point here is the maximum age of vaccination. we can vaccinate adults, older persons, of course we can, but each country, based on its data, each country, according to the circulation that there has been and the vaccination coverage, has set the year after which it's no longer necessary to vaccinate. In Argentina, by way of example, those born before 75 don't have to be vaccinated. That's why it's very important for us to be clear about the epidemiology and as well to also have clear what the vaccination coverage has been. That data is available. And that's what the technical guidelines are based on. Now, a single dose at the right age, even if it's given after 9 months, there can be a 15% primary failure rate. Now, this is another point I want to stress, and what we're recommending is after 12 months. If you're going to give the vaccine at 9 months, there's going to be zero protection. 88.7% zero protection at 4 to 6 weeks. So that's where it's the most effective. The efficacy and zero conversion has a direct correlation with the age and the age at which this first dose is applied. Now, the second dose, we can see it clear, the reason why we give it. And we attribute that primary failure, or rather we're trying to make up for or cover that primary vaccination failure. Now, look here, and you really see the difference between receiving one dose or two doses. Zero protection with one dose, 89%, two doses at 100%, and furthermore, the susceptibility profile, if I have zero protection rather, if we're going to eliminate the disease, there needs to be a robust routine schedule of the vaccine applicated, which is 2 doses. Now, something else that's very important is to follow the population, and the second dose is going to offer immunological memory that is sustained over decades at a high level. That's to say that if at the pediatric age I was vaccinated or later, and then as an adult there's an outbreak, but if I had those 2 doses, then I can rest assured that I'll be fine, because it's not just the antibody response, but the cellular response that matters. We know that immunological memory will be sufficient to protect people. So that's why it's not necessary to re-vaccinate after one person has been given 2 doses initially. Something else that's of concern to us is the simultaneous use of these vaccines with others. It's always very important to remember the type of antigen. If I have the attenuated virus, if I have to give another attenuated vaccine with intervals of 4 weeks for the rest of the vaccines, we don't have any problem. So if this is an influenza vaccination campaign or pentavalent vaccine has to be administered, we're not going to have any problem with the intervals, because we're talking about the fact that this antigen doesn't replicate itself. So that's why it's very important to be very clear about the type of antigen we're dealing with. Now, the administration of the second dose is done independently of the coverage that there may have been throughout the country at the first dose, based on all of the reasons I've already given you. But clear, if you have patients that have received the anti-tetanus shot, anti-rabies shot, immunoglobulin 2 doses, we know that an attenuated viral vaccine, in this case for varicella or double or triple viral. You can get 400 milligrams per kilo, in which there's a high concentration, and you'll have to wait to administer the attenuated viral vaccine for a longer time. Now, a standard one or another type of situation in which the interval is of months or lower. That's why we have to keep make that clear in our indications. Now, key point or key points. If the vaccine is administered in cases in which 2 prior doses have already been received, but the person didn't know that, doesn't remember, doesn't have the vaccination card, there's no greater risk. Now, if it's a case of someone who has already had the disease, there's no higher or enhanced risk. And if the person has not been immunized, or that is, people who have been immunized will not transmit the virus from the vaccine virus. That's a very important concept to keep clear. These are vaccines, as we've said, as every attenuated viral vaccine has its contraindications, serious allergic reactions during pregnancy, for example. If the risk of a pregnant woman is theoretical, there have not been observed any fetal anomalies attributed to the vaccine. Another counterindication is of grave immunodeficiency. You have a list here of what that might be, contraindications that we also have to be clear about. If one takes immunosuppressants, because there's a difference between monoclonal antibodies and other schemes and suppressants, immunosuppressors, you have to keep that in mind. Now, in the case of an advanced infection of HIV and severe immunocompromised people, that has to be taken into account. Now, you can see here, you will know that before vaccination could be administered. There are groups that we do have to protect. Now, precautions. Now, if someone has fever and there's an acute case of the disease, that's not when you're going to vaccinate. Now, it may bring about a response, but over time, that fever disease, it's very hard to connect that to the administration of the vaccine. You have to really believe in the vaccine. We've talked about immunocompromised people. Another problem that's important in the region, those patients that have been diagnosed with tuberculosis should initiate that treatment before being vaccinated for measles. Now, false contraindications, you have to be aware of this. A pregnancy, as I said, that is, the virus is not transmitted by the vaccine. Now we talk about someone who is immunodepressed, someone who lives with a immunocompromised situation has to actually keep all those vaccines up to date, contrary to the concerns some people have. Asymptomatic HIV infections or slightly symptomatic women of fertile age, vaccines may lead to some adverse events, minor ones, because these are not reactogenic very much. You can have transitory fevers and convulsions. Now, there might be a case of fever, exanthema at the clinical level. We have to be careful about that because you've got children who have not been vaccinated and those who have, and so you have to see when you vaccinate, especially with broad circulation of the virus, the wild virus, whether the vaccine is to the vaccine or to the measles itself. In this case, as Gloria made so clear, it's very important to send the samples to the lab to undertake the diagnosis and to know if this is an adverse reaction to the vaccine or if that is the virus in circulation that the person is presenting. So let's remember how important it is to keep clear these differences, especially when you are administering a vaccine amid an outbreak. Thimerosal, we all know that it preserves the vaccine. It's not the same as methylmercurio. In our hospital, we undertook work with the University of Ohio with Dr. Vicaro, and one of the things we took samples for the basic schedule as well as for after one has received the second dose. And what we saw, and we can be certainly rest assured about it, is safe. Thimerosal is safe. It's been tested, and there's no association between autism and MMR. Now, other things to keep in mind. The zero dose. This is a very important key tool we use. Now, when it's epidemic, when there's a greater incidence in children under 1, you know that you have to use an additional tool before the regular schedule is applied, especially that is the zero dose. Infants have their own antibodies that they receive from their mother, but they are passive. So they don't cover the full first year of life entirely because these are passive antibodies for an infant. There is no active immunization. So the mother passes her antibodies along, and studies show that sometimes there is a proportion of infants who are still vulnerable. Before the 8th month, there's a window of vulnerability when you have these antibodies that can protect you up until 6 months, sometimes till 9 months. But evidently, you have to close that gap of vulnerability, that window of vulnerability, especially when there's an outbreak going on. And how do we close that vulnerability gap? Because that's a critical part that we have to be mindful of, because that void of protection resulting from this crossing of a reduction of antibodies and the age is covered by vaccinating the child earlier, and that zero dose does offer global effectiveness of 58% by 9 months, and after a full year, it's more than 90%. But clearly, the antibody titles are low, between 9 months and a year, but generally titers, but generally we have a short-term drop-off of antibodies. We don't have a good response. So definitive protection happens with the first dose at a year of age, and the second dose, of course, that will cover the primary vaccination failure. So when do we act to close that vulnerability gap? There might be supplementary vaccination campaigns in endemic countries when there are outbreaks in childcare centers or during traveling or at-risk areas. This is done, of course, in keeping with the competent authorities, and it's important to stress the importance of this first dose. A common question is, if I offer a zero doses, can I continue with the full vaccination schedule, the other vaccines? Of course, because this is an attenuated viral vaccine. So they can be given simultaneously or with a 1-month interval with another attenuated viral vaccine, but there is no problem with the zero dose. Now, Two doses ultimately is what has to happen. We need to set the example. The first one's to set the example and to staunch the transmission. This is key, and it's important to bear in mind that we can also be a source of transmission. The first line of healthcare workers in handling outbreaks. If we don't have the second dose ourselves, it's not just about setting the example, but we need to have our health team fully protected to carry out our work. So let's do this in advance and have our two doses. So challenges, good coverage, and that it be homogeneous. If you have susceptible people, well, you have a problem. We have to raise awareness and make people trust vaccines. And there's much information that will enable us to do this. So we work quickly in the first couple of days. That's key. Rapid response and timely.
Muchísimas gracias al
Thank you very
doctor
much,
Herminio y Angela Gentile. Hay muchas
Angela
preguntas
Jane
que
Tile.
ya
There
los
are
panelistas han
a lot of
empezado
questions
a
that the panelists have
enviar
already
y
started
sin
to answer
demorarlo, vamos
in
ahora a
the chat,
proceder
in the
a algunas
Q&A, but
preguntas que les
now we're
hemos
going
dejado
to
sin
move
contestar
to some of the questions that
para
we have not yet
continuar de
answered so
forma
that we can do
en este
so.
espacio. Entonces, voy a empezar
Now,
con una pregunta para el doctor Herminio.
a question for
En el
Dr.
sarampión
Ernio.
modificado,
In
es
modified
posible que no
measles,
haya
is it possible
exantema
that there
evidente,
not
pero
be
sí se
evident
presente fiebre,
exanthema,
tos y
but
coriza?
um,
Adelante, doctor.
fever, cough, and coryza or
En sarampión
running
modificado,
nose? Now, in modified measles,
suele haber fiebre. Lo que puede
yes, there can be a fever.
ausentarse es alguno de los
What
síntomas en
might be
prodromo.
missing are
Puede
some
haber
of the
coriza, puede
symptoms in
haber
the
poca
beginning,
tos.
cough or
Siempre hay un brote.
coryza. There's
Lo que pasa es que el
always
brote puede
an
durar muy
outbreak,
pocos días.
but it may last just a
Es un
couple of
brote corto. Por
days.
eso les presenté ese caso. Nuevamente, anecdóticamente, lo que puedo decirles es
Anecdotally,
que
I can
cuando
tell
vi el
you that
caso,
when I
esto no
saw
me parece
a
sarampión.
case, that case I referred to, and it didn't
Inmediatamente
seem
respondí,
like measles,
esto no es sarampión
but then
clásico,
that was my
no es
initial
sarampión
reaction.
típico,
It's not
pero puede
classic
ser
or
sarampión
typical
modificado.
measles, but it
Y
may
esto
be
ya fue
modified
descrito hace
measles.
muchísimos años
And that's something that was
en
explained
el texto de
along
club
many
cuando
years ago.
aparece una sección donde habla de sarampión modificado.
There's a
Y
section that
nuevamente para el
addresses
caso,
modified measles
sí tuvo fiebre, tuvo
in the
brote,
books, and so yes, there
pero
was a
tuvo una
fever
secuencia de muy corta duración,
and there was
poco
an outbreak,
sintomático.
but it was mostly
La
is going to be
duración
the
no es la
same as
pregunta, pero
measles, and the length of it's not going to be the same, the modified
Muchísimas
versus
gracias,
the
doctor
unmodified.
Herminio.
Thank you very
Hay
much,
varias
Dr.
preguntas
Ermenio.
en
There are
relación
a
al
number of
esquema de
questions
vacunación
regarding
del
the vaccination
personal
schedule or
sanitario.
scheme
Para la
for
doctora Gentile voy a
healthcare workers.
preguntar,
For Dr.
voy a
Jane
resumir las
Teal,
preguntas
I'm
porque
going to
son
ask
parecidas.
her to
En
address
general,
this.
la inquietud es la
So the
siguiente.
concern is as
Tengo
follows.
la pregunta sobre la vacuna SR que se
The
administra con una dosis
SR
única
vaccine, which is
dos
administered as a
En
single
el caso
dose,
de no contar con la
but if
SR, si se
we
puede
don't
administrar
have
la
that,
vacuna
can
triple
the
SR
MMR be
en adultos
administered
como dosis única. ¿Qué tan cierto es
as
que
a
cuando
single
un
dose?
adulto se coloca la
If an
triple viral
adult
puede desarrollar
takes
paperas? Es la
MMR,
primera pregunta. Y la segunda pregunta guarda
can that person
relación
still be
con el
susceptible? Now,
esquema
the
de
second question has to
vacunación
do with
en
the
el
vaccination
personal
scheme
de salud.
in
Si dicho
healthcare
personal
staff. If said
recibió una dosis
personnel
el año
has
2022,
received in
si se debe
2022 one
completar el
dose,
esquema con una
should
segunda
a
dosis
second dose
o si
be
se
given to
debe
complete the scheme,
iniciar nuevamente el esquema.
or
Adelante,
should it
doctor
be
Gentile.
the whole scheme be done again? Thank you very much, Panela.
Thank you, Pamela. We can use the MMR in adults and no problems. And I can say even more here in Argentina. I'm sharing our experience in a hospital. Recently, we began the flu campaign. We had the flu on the one hand, and then the MMR. And everybody goes through that, the health personnel. If you did not have the 2 doses validated, then they were giving the MMR. And we usually use MMR, and there are no counterindications. So either the double or the triple vaccine, what each country if they need it, because the health personnel must show 2 doses of a vaccine. That is very important. So it doesn't matter how long it has elapsed. The outlines and the schedules are the same. This is not only for the health personnel, but it is also for young people, for teenagers. If I give them 1 dose a year, and they come to the age of 5, or they come after 5 or 10 years, and the second dose was not given to them, I don't use the 2-dose scheme. I give them the second dose, and with that, I complete the schedule. What is important is for people to have the second dose. They need 2 doses of a vaccine. They can use the double or the triple, MMR or MR. And I like the question about the MMR in adults, because this has happened as a regional committee. We've seen this. To have these situations and consultations where we've seen countries with an outbreak, and we've clearly stated that what is important is to use a vaccine available in the country. That's the most valuable thing. Thank you, Doctor. Can I add to this? Yes, Doctor, please do so. Angela, I believe that it is also worth our while to say that in the current MMR vaccines, particularly the mumps element has an attenuated strain in human cells, much more attenuated, which gives us much lower heterogeneity than other strains that we had previously, particularly the one that is feared or severe. Yes, yes. And this was said very well in the presentation. What are the strains? And that we don't currently have the contribution of the severe strain, which was the greatest risk. And let me say, because I believe that we're coming to the end of our presentation, what I tell my residents here in the hospital and what we dictate when you have acute exanthema fever, a patient with fever, acute exanthema, that is a suspected case of measles. The next day, the following day, I begin differential diagnosis, whatever you want. But as soon as I see the patient, we report the specimens if we see this. The problem is transmission within institutions, having safe paths within institutions. That is what we try to do in our hospitals. So if we have a fever, acute exanthema, you don't even think about it. It could be measles. Then I could think of other things. I do 3 or 4 key things. And these 3 or 4 first things are not debatable. And later on, we can talk about it. We take a look at the presentations. I loved the presentation with the child with all the differential diagnosis, but we cannot waste time in that first contact of a girl, because I'm a pediatrician, but it could be a child or an adult in the first contact with a health team, the first contact in hospitals, and then we can save safer paths, because something else that happened to me in my experience in my hospital also is that you send the mother with the tube to the lab. She cannot walk around. The mother cannot just be walking around on the tube, because I'm suspecting that this could be measles. With Herminio, we try to always share experience, and for this to be useful, that it be used and working everybody together. Excellent, excellent, Angela and Herminio. Just one thing to add to this question, and then I have another question for Herminio. There's a question that is highly related to the vaccination schedule in adults with MR. So what happens if I have adults, be it health personnel or not, that have a 2-dose schedule, but the antiviral titers are negative? Are we to use one booster and to repeat once again the antibodies titers Angela. No, absolutely not, because you don't measure immunity, but also cell immunity, not only in the fluids. And when we see a drop in IgG titers to non-detectable levels, when you get in touch with the wild virus, there's a memory response and heightened antibodies. So we have to remember that it is not only the fluid, the presence of IgG, but also the cellular response. And that is why you say with 2 doses, we're okay. Perfect. Thank you very much. So we now move on to Dr. Herminio. What is the way to deal with this in pregnant women? When am I to use immunoglobulin? Any change depending on the pregnancy trimester? Well, a pregnant woman, as has already been mentioned by Angela, cannot receive a vaccine with attenuated virus, as is the measles, rubella, or the MMR vaccine, any one of these. And also to include chickenpox. We shouldn't give it to a pregnant woman. So if I have a pregnant woman that has been a contact or has been in contact with a case, perhaps the best way of protecting this woman is with immunoglobulin, passive immunity. We don't have any other way. If the contact is clearly evident, if the diagnosis of the case is documented, particularly with TCR, then we have to protect that pregnant woman, because that pregnant woman, as I showed you, there are several studies. There are meta-analysis that brings together 29 studies with more than 400 pregnant women with a fatality of 5%. The normal fatality rate is around 1%. In developed countries, it is lower than 1%. So a fatality of 5% is extremely high. Complications, more frequent complications for her, and complications for the future baby, premature birth, and even abortion. So we must necessarily protect a pregnant woman. And Camila, with your permission, I'd like to add something. It seems to me I have like 3 major groups for the use of gamma globulin for managing contacts. Pregnant women, it is very clear, as Emilio just said. Here in the hospital, many a times we have immunocompromised patients, and I cannot give them any vaccine when these are close contacts and you have to protect them. And this happened during the last outbreak where Alvaro showed the 35 cases, or even in prior outbreaks, when you have an immunocompromised patient, also in managing contacts, when these are close contacts, you cannot block with a vaccine, so you have to give gamma globulin. And the third situation is in younger than 6 months. Between 3 and 12 months, I can give them a vaccine, a double viral vaccine, but I cannot do it in someone younger than 6 months, because we know that we have maternal antibodies, but we don't know how much they will block. So this would be another group of concern. So it seems to me that countries should have an endowment of gamma globulins for very specific situations, and we know that they're precisely specific because we don't have a campaign for globulin. We do it for vaccines, but clearly sometimes we have to protect them, and to protect them even more in these 3 groups, so we have to analyze them and to take into account with Gigi. So let us go into another question, several questions that are related to modified measles. Dr. Herminio, could you please indicate a modified measles changes the clinic of exanthema? Could they have other symptoms such as adenopathies or arthritis? No, that is not described. This is only described with rubella. Rubella as a disease in children. It is a very non-symptomatic. A child that has rubella has an outbreak that lasts 3 days, very few symptoms, almost no prolobes. But in women or adolescents and teenage women can have rubella and can have manifestations in the joints, arthralgia. We don't have any arthralgia because of measles, and much less in modified measles. So I don't know whether Angela has anything to add to this. No. No, very complete response. That is true. Another question, follow-up question on modified measles, Dr. Herminio. Is there an incidence of modified measles that has been documented in outbreaks, measles outbreaks? Perfect. Let me see. I have my own perception of what was happening here in the country. What is happening here in the country, we have like 50 cases now, but we see how they've spiked during this month of April. We see that most of the cases are happening in the Puno region, specifically in Sandia and in another Puno province. Where they got the disease, where the contagion took place, I believe that this happened in the February carnivals, in the Candelaria holiday in February. But, and the big but is that from February, or at the end of February, March, and April, they have the incubation time that is quite large. So my suspicion, and this is my suspicion, is that the first cases got the contagion during the Candelaria festival in February, during the carnivals in February in that region, because we have tourists coming from different places in the world, and we also have people from Bolivia. So the first cases must have been with modified measles. So it is undetected. And that is why the emphasis that Angela was giving us, every outbreak with a measles outbreak should be considered until the contrary or the opposite is proven for the purposes of this campaign, so as not to have any measles cases or any outbreaks. So clearly what we see now in this outbreak in Puno, which are most of these, I believe that over 40 cases in Puno and very few cases here in Lima. I believe that 2 or 3 in Lima. I believe that what we see are cases that are secondary cases, and the first one were not seen or undetected. Thank you very much. Just one comment. Following the idea that Herminio was putting forward, it seems to me that what we're considering is real. The concern of this measles that takes place when you have a prior vaccination dose or one prior of modified measles. But we must not forget what we were shown during the first data, both Alvaro as well as Gloria. They showed us that above all, we'd have people that are unvaccinated, children with 0 dose, no vaccine, unvaccinated. The reports, such as the unique report by WHO and UNICEF, where we see the large number of children with a 0 dose. So they clearly showed us about whole region. So the major issue is vaccination coverage and unvaccinated patients. We must have a clear understanding of modified measles, because this is what can lead to confusion, perhaps during the first contact with the health team. I'm in hospitals, in a health center, and maybe I see an adult or a child with this cater as perhaps what was studied at the time. I was a resident and we were looking for the Koplik. We were looking for each one of the elements of measles and the Koplik spots. And now we have very sensitive definitions so as not to miss not one single case. So clearly what happens is that sometimes these modified measles can take place. That is why we have to analyze them. And Emilio described them perfectly, without forgetting that we have measles and unvaccinated. The coverage is low, and we have to work on having high coverage rates that are homogeneous, because there are places in my country with very low coverages and others that are better. And another point that I always bring up is that a child that is in a situation of risk, because they have to vaccinate at the age of 1 year, and in keeping with what each country has, 15 months, 18 months, that varies. But until they receive that schedule, many a times that they receive the schedule at a later date, and you have to complete it, but later than what is customary. So during how long were they at risk without completing the schedule? That is why we have to do things on time. The issue is vaccinating, and the second point is the timeliness. And I believe that this is a bit and something that is a wonderful message. That is to say, look for the unvaccinated. And also, not to stay in hospitals and health centers without doing anything. You have to go out and look for these people because usually these are very vulnerable population. And if you don't go out and look for them, sometimes we don't clearly see the need for vaccination in these people because their needs address other things, a population that is at a lot of risk and maybe daily food, a lot of kids that is highly vulnerable. So we have to go out and look for them because if you stay there in an institution, these are families who will not make it to the institution. So it is key. It seems to me that we have to avoid these pockets, work in a territory with the leaders of the community precisely to help vaccinate all these groups. Excellent, Angela. We have to close this issue of modified measles. There are other questions for the experts, and I will invite Dr. Gloria Rey. There are several questions that are related to the diagnosis, the diagnostic test in the lab in order to identify modified measles. Dr. Rey, please go ahead. Thank you, Pamela. Initially, I'd like to echo what was said by Dr. Herminio and Dr. Angela. These cases of modified measles are very few and far between. So what we should expect are cases of classical measles, but it's important to alert, to have the capability of detecting them and to be able to document these, to typify the cases. The confirmation of a case of modified measles will call for several laboratory tests. And thus, it is important to see the need for obtaining the specimens that we've obtained previously, blood test, respiratory specimen, and urine, so that the lab can move forward with the relevant studies. Usually the IgM serological test, what is expected in this case is a modified measles. Since these are cases that have had prior immunity, it is important to recall that IgM can be positive or negative, because we have to remember that this is a marker of a recent infection. It is a first response produced by the immune system. However, some cases of modified measles have been documented that have a positive IgM, and that IgM, if we detect it, it is usually less intensity and less duration. But what these cases of modified measles will always show is an IgG response. In very early responses, they already have an IgG, and that IgG usually has a high concentration. And because of what has been said here, practically we see a stimulus, immunological stimulus. Therefore, the antibodies, the IgG antibodies immediately rise. What is important to document this is molecular tests. So we have to document the presence of the virus. And therefore, a PCR test should be positive. And ideally, it is also desirable to have a sequencing in order to have the documentation of genotype. But if it is not required, ultimately you can have good typification with IgM, IgG, and PCR tests. Ideally, I insist that the entire battery of tests gives you greater strength in order to document these cases. What is important is to remember that in general, these cases excrete the virus in a lower concentration, but we've also seen that these cases can transmit the disease. They can transmit the virus, and if they are prone to get it, they can also transmit the measles virus, particularly to communities that are susceptible to getting infected. Thank you very much, Dr. Rey. Let us now switch to another topic on fetal manifestations of measles in pregnant women. Dr. Hernandez, what can you say about this? In fact, what we know is that the measles virus is not teratogenic. The virus, the measles virus, can kill the fetus because of the severity of the infection, which is what could happen with influenza, as has happened with COVID. the severity of the infection or the complications
puede tener la mujer que
that the pregnant woman can have
mucho más severa.
as a much more severe disease. It is the severity of the infection, what can lead to abortion or to stunting in growth. But the virus is not teratogenic. The rubella virus is teratogenic. This is very odd. The rubella virus is a virus that in practice is not very symptomatic, but it does have an appetite, and I say it like that. It does have an appetite, a voracity for the embryo tissue. It does break away with the genetic material, breaking it down into different cells, the central nervous system, the eye, the heart, and it leads to congenital rubella syndrome. But nobody has described fetal manifestations because of the measles virus. And Pamela, I would like to add something in connection with the vaccine, and something that I brought up is that if a pregnant woman, unbeknownst to her, receives a MMR that contains the three diseases, it is not an indication of abortion by no means. That is also very important. Why? Because even when I remember that we had these huge campaigns to update things, and then the campaign for men and women, we emphasized this. When we worked with the vaccine for women, we emphasized very clearly the situation, because it is not an indication for abortion having received unknowingly a double or triple vaccine. And it seems to me that this has to be stressed, because sometimes there's a lot of anxiety in these situations in the families, and it is important to
Gracias, doctora Gentile.
stress this. Thank you, Dr. Gentile. As was presented, we have cases in measles in adult people. Several questions are related to the age limit for the application of the MMR vaccine or the MR vaccine in adult population. If you should vaccinate people that are 60, 62, 65 years of age, 58 years of age, what can you say, Dr. Gentile? We don't have any counterindication. If a person that is 60 years old, they never received a vaccine, an MMR or an MR, they could be vaccinated. What happens is that there's some thoughts about this. First of all, how the virus has circulated and the outbreaks that we've had previously, because it is very odd that a person of that age, particularly with the free circulation that we had in different areas in Latin America and the different countries, we have to take a look at the pattern, the circulation pattern in each country and these outbreaks. But it is very strange that they came to be that age with a respiratory transmission disease. I think of the replication coefficient 16 to 18. Every person that has the disease, they give it to 16 or 18 people. Remember, in COVID, it was 6 to 7. It was terrible. So clearly, if we don't have in the country a vaccination policy with very good coverage, it is not very customary to find someone who's 60 years old that are prone to be infected. No doubt they've been in contact with the virus at that age. But let us assume that they think that they've never been exposed or they want to be vaccinated. There's no risk about safety. But I'm absolutely convinced that at that age, and no doubt they've been in contact with the virus, and it is very uncommon to find someone who is prone to be infected. That is why the technical guidelines, the guidelines say those that are born as of this year or before that year are considered that they're not prone to be infected. In Argentina in 1965, because we established that comparison, how the virus circulated, the outbreaks that we had in a disease, as was well said by Herminio, a very high respiratory transmission with a virus that is suspended in a replication coefficient of 16 and 18, then we have to understand that it is very strange to find someone who's prone to be infected at that age. But going back to the vaccine, it is safe, no problem. Excellent. Excellent, Angela. And there are a couple of questions related to how complete the schedules should be, the implementation of vaccination campaigns where we vaccinate in dirty and dry schedules. So they're asking about this, and also Dr. Wittenberg has some thoughts to share with us. What happens if I have children under the age of 5 with complete vaccination schedules, but a vaccination campaign is going on and they want to have the vaccination? And I would like to hear comments of Dr. Gentile, Dr. Emilio, and Dr. Wittenberg. Well, in general, and I showed this on the slide, the fact that we have additional dose do not increase adverse events, because many times what happens is that you lose the vaccination card, or it happens that having had measles, there are no family background information. You can consult and check it. If you have had measles, and there's no risk if you have the complete schedule. You know now that since the countries are doing things by name, you already know whether you have 1 dose or 2 doses. And many a times during the campaigns, working with these names in the programs, you can see things better. And I say this because in Argentina, we included this as of 2023. So now, when we had the second dose that was given between the age of 15 and 18 months, and in our area of an outbreak where we had this cold campaign because of the outbreak, this was very helpful, nominalizing this, because you logged into the system and you can see whether the person had the 2 doses. And that's a key tool. And I say this because it was later on something that came up in the campaigns. Because during this last outbreak in 2025, we were able to deal with it differently because we had the names of these people. And in the past, we used to deal with this because they went and they were vaccinated, dirty vaccination. They lost the cards, the vaccination card. People don't know, they don't remember. And so we vaccinated people. So my response would be, if we have measles, prior measles, or complete schedules, and they receive this as a dirty vaccine, in quotes, no adverse events and no problem and no counterindication. And part B is it's really good to have the names of people, because this way you can log in to see whether you have 2 doses and to be able to face the campaigns with other characteristics. And I say this because the National Commission, and I'm heading the National Commission here in Argentina, when we analyzed this, it was a plus to have the names of people. And it I thought that it was so good that I wanted to share this with you. Excellent, Angela. Herminio, any comments in connection with this? No, perfect. And there's another question for you, Herminio. Álvaro, please. I wanted to say something about what Angela brought up and about the question in particular. The campaigns that are indiscriminate, usually in our region, are known as follow-up campaigns, follow-up immunization campaigns. And these follow-up immunization campaigns have been an essential strategy in order to achieve elimination and to support the immunization. It is not only a matter of reaching the population that usually has access to health establishments or health services to receive the 2 doses. This is an additional effort deployed by the country to even reach our populations when previously we were not able to reach, and to complete immunization schedules or to begin these schedules. And as Angela was saying, we're talking about the 90s, where we had a registry that was in paper, but where it was very difficult to be able to check the immunization background for each one of these children that needed to have their full vaccination schedule. So this is a reason for which we implemented these follow-up immunization campaigns in an indiscriminate fashion. And nowadays, it is still a challenge in many countries and in many areas in the countries. Obviously, the presence of electronic vaccination records helps us discriminate those that already have complete schedules and those who don't. But in these situations, it is still important to record that background information during the implementation of the vaccination campaign to see if I vaccinated the 95% or that 100% of children in that area where I have to carry out the vaccination activities or not. Nowadays, we have to start using these tools and to try adapting these immunization strategies, which are essential, with the use of new technologies and adapt this to our reality. Over.
Totalmente con Álvaro, ¿no? Por eso
Para el
muy
doctor
buena
Armino, si hay
la pregunta.
diferencia
Perdón.
entre rubeola y rociola. No sé si me pudieron escuchar.
Roseola,
Si hay
Cruella, I don't know if you can hear me.
rubeola y rociola.
Oh,
Doctor
is
Armino.
rubella and roseola the same?
No sé si me confunde cuando no se utilizan los términos.
Sometimes a little bit confused when the right terms aren't used.
Hablan, por ejemplo, de rociola para
Now, when they speak of roseola,
exantema súbito.
I think that's commonly used for sudden exanthema.
No me gusta mucho utilizar términos que no son más
I
estandarizados.
don't really like using a non-standard
Parece que
terms.
algunos hablan de rociola
It seems
para
like some do speak
exantema
of
súbito.
roseola as a
Exantema
sudden
súbito,
onset of
exantema súbito.
rash
Esa
or
enfermedad, si la quieren
exanthema,
enumerar
but
así,
that's
la descripción
just called
hace
sudden
muchos años.
exanthema.
Muchas gracias, doctor
Thank you,
Herminio.
Dr.
Doctora Ángela, ¿algún
Herminio.
comentario?
Dr. Angela, any comment?
Después de lo que dijo Álvaro, que me pareció excelente, es
After having
marcar
heard
que si se vacinan
Angela, I do think it's very
adicionales son
important
seguras. Ese es el gran
to
concepto
stress
que hay que tener
that
claro.
this is safe. That's the
Después, por
concept you have to
supuesto,
keep
están
clear.
todas las
And of course,
estrategias,
you have all the
pero la
strategies.
seguridad de la
But
vacuna,
the safety
creo
of
que
the
hablamos bastante en
vaccine,
la
I think
charla,
we've
¿no es
already talked
cierto?
about that a
Es la
lot.
tranquilidad de la
And
seguridad de la vacuna.
we can all rest
Independientemente
assured
del
how
número de
safe it is,
dosis,
regardless of how many doses
independientemente también
one
del tipo
takes
de cepa que se está usando,
or
podemos
the
tener
strain
tranquilidad y
used,
ser
we can
vacunas
be certain,
seguras y efectivas,
at
y
ease,
que lo podemos
rest
usar
assured that
con
they are
toda
safe
tranquilidad. Y este es el gran
and
mensaje
we
que me
can
parece que tenemos
use
que dar
them, and
también.
that's the biggest message we have to convey.
Excelente.
Thank you.
Bueno, creo que estamos llegando al término de nuestro
I think we have
Nos hemos excedido en
arrived at the end of our
minutos.
webinar. We've gone
Sí,
over
hemos tratado de
by
contestar
30
todas las
minutes,
preguntas, pero de
and
todas
we did
maneras,
so to answer all of the questions as
vamos
best
a
we
seguir
could,
contestando a través
but
de
we will continue to answer the questions through the
llamadas
chat
en la página web del
and on
evento.
the
Así
webpage
que,
for the event.
muchísimas gracias a nuestros
So,
panelistas,
thank you
a
very
la
much.
doctora Gentile, al doctor Herminio, a
I
Álvaro,
thank
a Gloria y por
Dr.
supuesto
Herminio,
a
Alvaro,
nuestro
Gloria, Angela,
ponente, el doctor Daniel Salas.
Dr.
No sé si
Daniel
Daniel
Salas.
desea dar algunas palabras de cierre.
I don't know if he has any
Para
closing
esta
remarks he'd
reunión,
like to make.
simplemente recordarles que en la página del
I would just
evento
remind you
vamos a
that
estar
on the webpage for the
dando la
event,
grabación completa del mismo
we will be
junto con
providing
las
the full
presentaciones y
recording
algunas preguntas y
as well as all the
respuestas que se
presentations
han dado en
and the
este
responses
espacio.
given
Daniel, por
to the
favor,
questions posed.
Sí, muchísimas gracias, Pamela, y muchísimas gracias a
Thank
toda
you,
Ángela, a Herminio, y obviamente a Álvaro, y a
Angela,
todos los que
Arminio,
estuvieron
Alvaro,
participando
Gloria, everyone who
activamente.
took
Creo
part
que
actively in this event. It was quite dynamic. There were a lot of questions,
creo que pudimos abarcar
all
prácticamente
very
todas.
interesting. I think we were able to
Creo que
cover
queda la
most of them.
grabación.
But of course, you
Después
do
queda
have the
entonces
recording, and if you have any further
también
questions,
correo
feel
en las
free to
redes y
write
los
us at
grupos que
our
tenemos de vacunación.
email here at PAHO. We will
Entonces,
try to
tenemos
answer
todas
them
las
all.
guías y los cursos que tenemos disponibles para
And of course, we
cualquier
have courses
duda,
available
cualquier
as
respuesta
well, and
y poder
manuals or
intervención
guidelines
ante los
or,
brotes de
or
sarampión.
handbooks
Muchas
to
gracias.
address some of
Creo que
these
fue una muy buena
topics. So thank you
tarde
very much
a
and enjoy
todos
your
los que estuvieron participando.
afternoon.
Adelante.
Listo, muchísimas gracias y estamos cerrando la
Thank you.
sesión.
Then we
Buena tarde a todos.
will close the session.
Buenas
Everyone,
tardes.
enjoy
Buenas
your
tardes,
afternoon.
adiós, hasta luego.
Chao, Ángela. Chao.
Chao, Herminio, adiós, un
Chao,
saludo
chao.
para todos.
Álvaro, Pame.
Hasta
Muy buena
luego,
semana, que
muchas
estén muy
gracias.
bien.
Salas.